Hello, I'm Dr. Farnaz Haji with the UCLA Division of Surgical Oncology, and I'm pleased to be here to discuss some topics in breast health, and more specifically, the role of one of the more modern techniques in breast surgery, nipple-sparing mastectomy. I have a background in art, so besides the medical aspect, breast is always very fascinating to me from an art and historical perspective as well. Breasts have been featured in ancient, in modern sculpture, art, and photography. The female breast has always been a symbol of beauty, fertility, and femininity. In disease, however, it has also challenged physicians since the ancient times. Breasts have taken different symbols throughout the history. They have been perceived as sacred in some historic portraits. There was also a transition from sacred breasts of Middle Ages to the erotic breast of Renaissance. And ultimately, the political breast, as shown in this image of liberty, leading the people in French Revolution. And of course, we cannot forget the commercialization of breasts in various products marketing. Throughout these periods, we have also made great progress in the medical management of breast diseases. The historic milestones that have brought the surgical management of breast cancer to its current state are truly remarkable. The first image on the left shows a 17th century mastectomy, surgery which ruled the cancer therapy at that point caused substantial disfigurement when a knife or historic instrument were applied to the breast. The middle picture shows a radical mastectomy. Dr. William Halsted in 1894 published his work with radical mastectomy at Johns Hopkins, where he removed breast, all of the underlying chest muscles, and all the lymph nodes of the axilla as a treatment for breast cancer. The Halsted radical mastectomy, which was once considered the ideal cancer operation, these days really no longer has a place in the routine management of patients with breast cancer. And on the last picture on the right, you can see an example of modern bilateral mastectomy with reconstruction, where patient has chosen to get a tattoo on their incisions. As you can see, breast surgery has truly undergone a revolutionary change, leading us from the conventional radical mastectomy of Halstedian era to the current motion of skin-sparing and nipple-sparing mastectomy. Perhaps the most significant change in today's approach to breast cancer is the reliance on well-controlled prospective studies to evaluate outcome and determine the appropriate surgical procedure. One reason that I'm able to sit here with you today and provide this talk is thanks to many previous surgeons and women's healthcare advocates who championed for better healthcare and insurance coverage for women with breast cancer. The Women's Health and Cancer Rights Act of 1998 stated that if an insurance company covered mastectomy, it was required to cover reconstruction surgery as well, including the other breasts, to produce a symmetrical appearance for the patient. It would also provide coverage for prosthetics for lymphedema as a result of lymph node dissection. This truly set the stage for immediate reconstruction after breast surgery. Prior to this, reconstruction was generally not performed or recommended on a regular basis. What about mastectomy versus lumpectomy? That's a very broad topic that hopefully we'll have another talk about that. But basically in mastectomy, we remove all of the breast tissue, and in lumpectomy or partial mastectomy, we only remove a segment of the breast which has the cancer. Despite multiple studies showing equivalent survival rates, whether a woman underwent mastectomy or lumpectomy and radiation, around 2004, it was noted that mastectomy rates started rising. This trend was seen nationally as well as in many individual institutions. So why would a woman want a mastectomy, a bigger surgery, instead of a smaller surgery for their cancer? This could be if they have multicentric disease, meaning that their cancer is not in one focus and there are multiple lesions, or a patient may have hereditary breast cancer or a larger tumor overall, or sometimes it's just patient preference. In addition to an increase in mastectomy rates for early-stage breast cancer, an increase has also been seen in contralateral prophylactic mastectomy, which is when we remove a breast that does not actually have cancer. Factors associated with an increase in prophylactic mastectomy rates are younger age, Caucasian race, higher economic status, or better insurance coverage, availability of reconstruction, availability of genetic testing, or patients being able to undergo a breast MRI. So let's delve into more technical aspects of breast surgery by talking about types of mastectomies which are available these days. To start with, I think it's essential to become a little bit more familiarized with the anatomy of the breast and some terminology. So what does the inside of the breast look like? These illustrations show the makeup of breast anatomy both inside and outside. Coming from inside out, we have the rib cage covered with muscles, and then breast fat intertwined with breast tissue, which is made out of ducts and lobules. This is then covered with more subcutaneous fat and ultimately layers of the skin. On the outside of the breast, at the center of the breast, we have the nipple and surrounding areola. In the armpit area, we have the axillary lymph node system, which drain the lymph fluid from the breast. If breast cancer spreads, it typically goes first to the nearby lymph nodes under the arm. Knowing if the cancer has spread to your lymph nodes helps the surgeon, or me, find the best way to treat breast cancer. To help find out if the cancer has spread outside the breast, a few lymph nodes under the arm, referred to as axillary lymph nodes, are removed and checked in the lab. You may hear about axillary sentinel lymph node biopsy versus axillary lymph node dissection. So what is the difference? In a sentinel lymph node biopsy, the surgeon finds and removes the first 2 to 3 lymph nodes to which a cancer is likely to spread. A radioactive substance and/or blue dye is injected around the nipple. Lymph vessels would then carry these substances along the same path that the cancer would likely take. The first lymph nodes the dye or radioactive substance travels to will be the sentinel nodes and removed. For axillary lymph node dissection, for this procedure, anywhere from about 10 to 40 lymph nodes are removed from the area under the arm and checked for cancer spread. Axillary dissection is usually performed for more advanced diseases these days and not routinely performed. So now let's talk about types of mastectomies. In total or simple mastectomy, which is a technique where we remove the whole breast, including the nipple and areola, and most of the overlying skin. In modified radical mastectomy, it's fairly similar to total mastectomy where breast and nipple and areola are removed, but the surgeon will also perform an axillary lymph node dissection, which means many or most of the lymph nodes from under the arm on the side of the tumor will be removed to check whether cancer has spread there. This technique is usually used for more advanced stages of disease, as I mentioned before. Some newer mastectomy methods may offer more innovative surgical options for our patients. One of these techniques is skin-sparing mastectomy, and that's when the breast tissue, nipple, areola are removed, but most of the skin over the breast is still saved. It's used when breast reconstruction is done right after the mastectomy is performed. How I usually describe this to my patient is that think of the breast as a pillow, and the skin of the breast as the pillowcase, and during the mastectomy, the pillow is then removed. In patients who have skin-sparing mastectomy, since nipple and areola are removed, patients have the option of getting nipple tattoo to recreate the nipple. These days, they do a great job by doing 3-dimensional tattooing, which looks pretty natural. Let's move on and talk more specifically about nipple-sparing mastectomy. Why are nipples important in breast surgery? Despite its relatively small size on the human body, the nipple gets a lot of attention, as female nipples are often perceived an intimate part. Covering them might have originated under Victorian morality laws in Western culture. Biologically speaking, the nipple serves 2 key functions. In women, nipples deliver milk out of the ducts within the breast to babies, and for women and men, they serve as erogenous zones as well. Oncologically speaking, traditional teaching always suggested that the nipple should be removed to decrease the risk of leaving breast tissue behind and local recurrence. Nipple areola complex is significant to women's body image and quality of life. There's also a growing public and surgeon interest in cosmetic approaches to breast surgery. Nipple-sparing mastectomy also provides the best natural envelope for reconstruction, preserving nipple, inframammary fold, and the breast contour. This could ultimately then decrease the need for contralateral breast procedures to achieve symmetry. Nipple-sparing mastectomy with immediate reconstruction has become popular because it tends to provide a very good, natural-looking cosmetic results with minimal scarring. A nipple-sparing mastectomy leaves in place most of the healthy breast skin and the nipple and the areola. Only the tissue contained within the envelope of skin around the breast is removed. However, it's important to mention, if you get a nipple-sparing mastectomy, you shouldn't expect much or any sensation in the nipples after the surgery. Also, your nipples may appear to be erect all the time or become flat and not have as much protuberance after the surgery. In nipple-sparing mastectomy, this is very similar to skin-sparing mastectomy. How I perform this surgery is that by making an approximately 8 centimeter incision under the breast at that inframammary line that patients have, and dissect the breast out from the overlying skin. All of the breast tissue, including the ducts, going all the way up to the nipple and areola, is removed. But the skin of the nipple and areola are preserved. The tissues under and around the nipple and areola are carefully dissected and checked by a pathologist. If no breast cancer cells are found close to the nipple and areola, these areas can be saved. Otherwise, this method is not advised. Either a sentinel lymph node dissection or an axillary lymph node dissection will be done depending on the type of specific diagnosis that the patient has. In most cases, the breasts are immediately reconstructed during a nipple-sparing mastectomy with either tissue expanders, breast implants, or tissue flaps. What are some of the advantages of nipple-sparing mastectomy? Nipple-sparing mastectomy is a single-stage procedure. It requires fewer resources, and it's therefore easier for patients. It gives an aesthetically improved outcome over nipple reconstruction or tattooing. Patients maintain their own natural color of nipple and areola, and they usually have a more natural projection and more natural shape. The disadvantages of this technique is sometimes some incisions, such as inframammary incisions, make it difficult to resect the upper pole or the upper part of the breast. Some patients may experience nipple necrosis or delayed healing of their nipple and areola incision. And as a result of that, they may have need for nipple resection or a second procedure if the subnipple tissue specimen ended up being positive with cancer. Additionally, the learning curve for surgeons who don't specialize in breast surgery is kind of high, and it may take some time for them to get accustomed to this technique. And there's also some increased operative time for this procedure versus skin-sparing mastectomy. Inframammary incision to access the entire boundaries of the breast are shown in this picture. So who is the ideal candidate for nipple-sparing mastectomy? Generally, patients with small to moderate breast size, healthy, non-smoker, minimal ptosis or sagging of the breast, and a small and node-negative type of tumor with no evidence of nipple involvement. How do we know if nipple is involved preoperatively? We haven't been there yet. Generally, I recommend a preoperative MRI for evaluation. In this example and picture that you can see the evaluation of candidacy for nipple-sparing mastectomy in a patient with a history of bilateral breast augmentation with implants. Image A on the left shows a mammogram that shows a new mass in the right retroareolar location as shown with the red arrow. There's no visible extension to the nipple or the skin. On image B, which is an MRI, on the right, it shows non-mass enhancement from the mass that continues to the base of the nipple, and it's shown with that yellow circle. Therefore, in this patient, she was not a candidate to be considered for nipple-sparing mastectomy. Although both imaging did show the mass at 1 centimeter posterior to the base of the nipple, MRI was superior for assessment of the retroareolar location, especially in patients who are considering nipple-sparing mastectomy. In the breast surgery world, we're making a shift in our philosophy and truly challenging ourselves to offer nipple-sparing mastectomy to more patients. Nipple-sparing mastectomy may be utilized in therapeutic cases to treat patients who have cancer or as a prophylactic case for risk reduction purposes. As genetic testing is becoming more prevalent in our patients' management, more patients with family history or increased risk factors present to us for discussion regarding prophylactic mastectomies. One group of patients that we have substantial amount of data about is the patients with BRCA or BRCA gene mutation. There are two types of BRCA, BRCA1 and BRCA2. Although this is not the only gene which may increase breast cancer risk, and at the time of a patient's diagnosis, I generally recommend a more comprehensive genetic testing panel beyond the BRCA genes. In BRCA patients, the cumulative risk of breast cancer by age 80 is estimated to be 72% for BRCA1 mutation carriers and 69% for BRCA2 mutation carriers. Additionally, the risk of a second contralateral breast cancer within 20 years of initial breast cancer diagnosis remains high. That's approximately 40% for BRCA1 carriers and 26% for BRCA2 carriers. With this data in hand, bilateral prophylactic mastectomy is highly effective in preventing breast cancer in high-risk women, reducing the risk by approximately 90% in women with increased risk from family history, specifically in women with BRCA1 and BRCA2 mutations. What are the indications for nipple-sparing mastectomy for risk reduction? If patients have genetic predisposition or compelling family history, or if they received thoracic radiation at age less than 30. This is endorsed by National Comprehensive Cancer Network, European Society of Medical Oncology, and American Society of Breast Surgeons. National Comprehensive Cancer Network guidelines support bilateral risk-reducing mastectomy for carefully selected women who desire this intervention. This includes patients with BRCA, TP53, PTEN, PALB2 mutations. They recommend surgeons and oncologists to discuss this with their patients who have these increased risk mutations. The superior cosmetic results of nipple-sparing mastectomy has been the primary factor driving the procedure's wide dissemination. However, nipple-sparing mastectomy for patients with deleterious BRCA mutation is still somewhat controversial. As testing for hereditary cancer syndromes and nipple-sparing mastectomy are simultaneously being used with increased frequency, understanding the oncologic efficacy of this procedure is very critical to us. This study published in JAMA in 2018 evaluated this question. They looked at this question that whether prophylactic nipple-sparing mastectomy is oncologically safe for patients with BRCA mutations. This review included a cohort of 346 patients from 9 institutions who underwent risk-reducing nipple-sparing mastectomies. They were followed between 3 to 5 years, and in this population, no breast cancers developed. What about nipple-sparing mastectomy in patients with cancer, so not as a prophylactic measure? This is a group that is a little bit more controversial. What are the cancer characteristics where nipple-sparing mastectomy is not recommended or contraindicated? The relative contraindications are if the tumor is less than 2 centimeters from the nipple, if the patient has extensive ductal carcinoma in situ or DCIS, if the patient has multicentric tumors, node positivity. We sometimes consider this if the nipple-sparing mastectomy is performed after neoadjuvant chemotherapy treatment and the patient had a good response to that. If the breasts have significant ptosis or sagging, large breasts, typically, as I mentioned previously, my threshold is approximately a size C cup. The patient is an active smoker. If they've had prior breast surgery, especially if incisions were done around the nipple and areola, and if the patient has a history of breast irradiation. The absolute contraindication, this is where we never recommend nipple-sparing mastectomy, is if there is a T4 cancer, which means the cancer has spread to the chest wall or skin, inflammatory breast cancer, Paget disease, which is a type of cancer in the nipples specifically, and tumors with clinical or radiologic evidence of nipple involvement, and pathologic nipple discharge. Favorable cancer characteristics for nipple-sparing mastectomy are a smaller tumor, not aggressive biology such as low-grade estrogen receptor positivity, no abnormal lymph node noted prior to surgery, and the tumor not sitting immediately right under the nipple. So these were the cancer characteristics. What are some of the patient characteristics? Complications associated with nipple-sparing mastectomy are mostly similar to other mastectomies, including bleeding, seroma or fluid collection, infection, capsular contracture from reconstruction. The only thing that there is a higher possibility with nipple-sparing mastectomy is the risk of tissue necrosis around the nipple areola complex. We do have some surgical techniques and modern modalities to prevent tissue and nipple vascular compromise. Where we do the incision can be optimized for better cosmesis and fewer complications. Additionally, technologies such as SPY angiography help us assess the perfusion and viability of flap tissue while we're doing the surgery. In the image on the right, the bright white areas show the blood supply to the tissue, and the black area in the middle indicates limited vascularity to the tissue. So what do our patients think about nipple mastectomy? There's a lot of emphasis about what our patients think, and I'd love to get them involved in the decision-making process. Studies have shown that nipple-sparing mastectomy affords better ability to cope with the trauma of having breast cancer. Additionally, patients who undergo nipple-sparing mastectomy have significantly higher reported rates of psychological and sexual well-being compared with skin-sparing mastectomy patients. These are 3 survey studies which looked at ranking for nipple-sparing mastectomy. Overall, 3/4 of patients were pleased with their surgery. They were very happy with the appearance of their nipples, less happy about the position, and not very happy about the sensation. Across these studies, factors associated with diminished patient satisfaction were higher BMI, large breast size and/or expander volume, and unilateral operation, and therefore it's very important to be selective in our patients for this procedure. I wanted to also briefly discuss some of the newer technologies that are coming up in the breast surgery horizon. Robotic-assisted nipple-sparing mastectomy is one. This is performed through a small incision with a robotic camera and small instruments attached to a robotic arm, which is controlled by the surgeon at the computer console. This is based out of Italy, and there are a few centers here in the United States which are using this in an experimental setting, but is not currently FDA approved in the United States. The follow-up after nipple-sparing mastectomy is pretty much the same as simple and skin-sparing mastectomy. There's no screening imaging needed. The assumption is that all the breast tissue is removed at the time of mastectomy. No mammogram, no ultrasound, or MRI is required. We do, however, consider ultrasound or MRI for any complaints or findings that the patient may have. And the rest of follow-up is according to recommendations based on the primary diagnosis that the patient had. In summary, the eligibility criteria for nipple-sparing mastectomy are evolving. Nipple-sparing mastectomy is an effective risk-reducing strategy in patients with gene mutations. The risk of new same-site breast cancer is very low after nipple-sparing mastectomy in BRCA1 and BRCA2 mutation carriers. Nipple-sparing mastectomy may be considered in appropriately selected patients with active cancer who meet the recommended criteria. Thank you for the opportunity to discuss this topic with you, and please feel free to reach out to me in my office in Santa Barbara or Ventura if there's any further question.